Hello everyone and welcome back. I'm Joe Chappelle and you're listening to episode 27 of the OBGYN podcast. This is the monthly checkup for November 2017, and to talk over some recent topics in medicine, I have with me Dr. Sarah Kim from Stony Brook University and Dr. Jerry Ballas from Baylor College of Medicine. Welcome, guys.
Glad to be here.
Good evening.
So before we get started, I just want to take a minute and thank Dr. Bergay for his excellent two-parter on antenatal steroids. The time and effort that he put into it was considerable, and I really appreciate his efforts. After his episodes, I had a couple of people reach out to me, say they want to get involved, do an episode or two, and the answer to them is yes, definitely. You know, from the beginning, I always wanted this to be by as many voices as possible, bringing their own experience and their own viewpoints. So if you have an idea for an episode, then please send me a note at feedback@obgyn.fm or in the Slack. And this brings me right back to today, where I have my two wonderful guests. And just so you guys know, I really appreciate you as well, and this stuff wouldn't be possible without you. So why don't we get started? So the first topic today comes from a study published in Pediatrics in October, and it looked at the effect of acetaminophen use on the rate of ADHD. Acetaminophen has long been one of the few safe medications that we have in pregnancy, so their paper definitely ruffled a few feathers. In their paper, they enrolled 95,000 women in Norway, which is an astounding number, and they found that women who reported using acetaminophen for 29 days or more in their pregnancy had an over 200% increase in risk for their child developing ADHD, which is huge. They also found that fathers who used it for greater than 29 days prior to conception also increased the risk for their child having ADHD. And then, strangely and conversely, if the woman used it for 7 days or less, it actually decreased the risk. Just to dig a little deeper here before I get you guys' comments, they did control for familial risk of developing ADHD, which is an interesting kind of phrase, and other major maternal medical conditions. And then the last thing is the ADHD diagnosis, importantly, was pulled from diagnosis codes. And so it obviously was not uniform in any way. So before I do my little rant on this paper, I'd like to hear what you guys have to say about it.
Well, I think we've talked about this on prior episodes with big data studies, where if you flog a data set of greater than 100,000 enough in different ways, you're going to get significant p-values. You're going to get confidence intervals that don't cross one. And this is just classic. And it just, again, the old adage of, association doesn't mean causation is just tried and true with this paper.
Mm-hmm. Yeah, I mean, I totally agree that the paper is making a huge leap of a conclusion just to say, oh, we found this finding, and because of this, acetaminophen causes ADHD. Because with this number, I don't think they account for, why these people are using acetaminophen in the first place, and the fact that it's just an association, a finding that they found, but they're saying that causes it is a huge jump. And I think that it's going to send out a lot of mixed, signals and mixed messages to whoever reads the paper and even to our patient population.
Yeah, so you guys basically stole my rant. But there were a few other things that I thought were interesting. One is that they used a baseline of 4%. And again, the diagnosis of ADHD is difficult. It's very subjective. What is a normal, 7-year-old versus an ADHD 7-year-old? I know plenty of 7-year-olds, and they're pretty hyper sometimes, especially around Halloween. And so 4% is what they use. In the U.S., that number is more like 8 to 11%. Now, maybe that's the way we diagnose it. Maybe that is just a difference in population, because Norway, like most Scandinavian countries, does tend to have a much more homogeneous population than we do here in the States. So that may be part of it. A couple other things I thought were really interesting is, like, kind of going what you said, Sarah. They asked the women if they took Tylenol and how many days they took it, essentially. But they didn't ask them how much they took or how often they took it during the day. And they also didn't ask them, like you said, why they were taking it. Right. And then the last thing is all of this data was done by survey. So they enrolled women at 18 weeks, and they asked them and the fathers, well, in the last 20 weeks or 30 weeks really, how many times have you used Tylenol? I don't know the answer to that question.
Yeah, I mean, there's obviously that recall bias that they're not really taking account.
But exactly. You're going to know if something is wrong with your kid. I mean, this is one of you set yourself up for some of the classic trappings of survey data looking for associations with bad outcomes or negative clinical findings, because again, parents are going to search for answers. They're going to go through every little thing they did to try to come up with an answer. And my other question would be, again, 30 days of Tylenol use. What is going on? Like, there's seems to be so many different confounders, both physically, socially, that may be going on beyond the pregnancy and before the pregnancy. That makes me wonder what else may be happening in this, parental child unit long after delivery.
Yeah, I mean, you're actually absolutely right. 30 days of Tylenol use, especially for the fathers before conception, that's a lot of Tylenol. That's a lot of days of using Tylenol. It's a little strange. Jerry and I have discussed this before, like Jerry said, but big data papers like this, or big data research like this, let's leave the paper out of it, is very, very, very useful and valuable when done correctly and used in the right manner. And I was actually listening to another podcast the other day, and they were saying what a cliche now that correlation is not causation. But I want to say that 15 times in this podcast because it's so true here. And all this big data does for you is point you in a direction. It says, there seems to be a correlation here between Tylenol use and ADHD. Now let us dig deeper and say, is there actually a link there? Is there a biological plausibility to that? And that's something that this paper didn't really address, is there a biologic plausibility for the fact that too much Tylenol, 29 days, whatever we're going to call too much, or a little Tylenol, 7 days, have opposite reactions on ADHD or opposite effects? It doesn't make a whole lot of sense.
No.
Right. So I think they use this paper in the wrong way, and it does a disservice to science. It's saying it's using this data to say something that's not true. Right.
I'm not saying. I mean, I think the study itself is flawed in many levels. It's not like the worst study, but I think because of what the conclusion from the study is, I think it makes everything kind of questionable more. The data itself is there, and that's fine, but concluding that long-term use of acetaminophen during pregnancy is associated with twice risk of ADHD in children, like that conclusion was too much of a leap, I think, so that it makes, I think this study may have been maybe a good stepping stone to be like, hey, maybe there is this association. What may be the underlying factor that may be causing this association? But to make that conclusion based on the data, I think that's what makes this even more flawed.
Yeah, and then it gets picked up by the media as well, and then our patients are asking us. And I originally came across this from a CNN article, and just to give the listeners here, the title of the paper was "Study Links Acetaminophen in Pregnancy to ADHD, but Experts Question Results," which is actually not a bad title. But there were other examples. This is the best one. There are other examples that basically just say acetaminophen is linked to ADHD. Right, and that's a disservice, and that's a whole different conversation between the intersection of science and media. But
you have to sell the ads that pop up on your website. I mean, that's the bottom line. And when acetaminophen is the only real tried and true pain medication we can give routinely, or fever reducer we can use in pregnancy, I mean, that's a built-in clickbait. If I ever did see
my doctor said it was okay, and now my baby is going to be harmed.
Right.
It's a tough one. I like the paper just for bringing up these these central points, and it's going to end up being one of the themes of this podcast is big data. So I'm sure we'll get back to it in another episode.
Right.
Mm-hmm.
Well, I just read these papers and I just get jealous. I mean, I just get jealous of all these countries that have this type of infrastructure for creating these kind of hypothesis-driven questions. Now, the conclusions you come up with from them can be murky at best, but they have an infrastructure to at least get the ball rolling on so many levels. Whereas sometimes in this country, we're kind of flailing for treatments and then taking a step back because suddenly something will come out a couple of years later saying, no, don't do that. We trying to replace oxycodone with Tylenol, Tylenol 3 with codeine, and now pediatricians saying codeine makes the baby's breastfeeding potentially sleepy and apneic, so don't do that. And it's just a constant struggle back and forth when you don't have an infrastructure to keep track of all this.
Okay, I want to stick a little pin in that your follow-up there from one of the previous episodes. But your point there about national healthcare systems and the used to do data, it completely segues into our next topic. So thank you, Jerry. That was fantastic.
Hey.
So the second topic we have today actually comes from the NIH. And it's an interesting one, and I want to hear what you guys have to think about it, especially in the light of the last paper. The NIH is launching a crowdsourcing effort to get more data about pregnant women. The program is called PregSource. Women must sign up for the program, and then they will be sent online surveys to complete during their pregnancy. They can also use it to track their weight, sleep, mood, nausea, and physical activity. And lastly, it will give them access to a lot of resources about pregnancy and childbirth, which I guess is how they're trying to sell it to the women. You get all this information. You give us your information, we'll give you information about your pregnancy. And this very much goes back to what you were just talking about, Jerry. Trying to get especially like hacking a way of trying to get real population-based data in the U.S.
Yeah, but the biggest thing I see is that this is a patient-driven, voluntary outreach type program that is probably only going to reach a certain homogeneous or potentially filtered population. You're going to get right off the bat. To me, I envision needing a iPhone with a good data plan and able to do apps, able to read English, and just having the time and motivation to do this outside of your doctor's visits. Right off the bat, I have in my head the archetypical patient that's going to do that. And is that data going to be helpful?
Yeah, no, that was literally the thought that went through my head. The article says it's free, PregSource benefits everyone, but it's questionable. Does it really benefit everyone? There's obviously problems with access. Not everyone has access to internet, like you said, as even like iPhones or application from this. And obviously you have to be able to read English. And something that actually the article says is it will help identify distinct challenges faced by subgroups of women, such as those with physical disabilities. And I wonder if those people will really be willing to use this application and this resource to kind of track their pregnancy.
All valid concerns. I had kind of the same things myself. Just for some clarification, it is a website, not an app. So it's platform agnostic. You can, as long as you can get to the web.
Even worse. Even worse, if you ask me. I mean, seriously.
Why do you think it's worse?
Well, no. If you think about it, you're trying to toe the line now between web-based when so many people have gone mobile, right? And so my guess it's going to be NIH-based. So do they have an example up and
there's
running
a website
yet?
for it.
Because I'm curious to see the functionality for it. And so I would almost think you need both, but I also think there needs to be a doctor's portal. This seems perfect to be the backbone of a perinatal database that's available to all practitioners where women access care across all spectrums?
I think, I'm conflicted. The first thing I thought about is maybe a couple of years ago, Apple released HealthKit for the iPhone, and really one of the first big people to jump on that was Stanford with a cardiac study, which again, same thing. You had to opt into, and you had to do all the data, and it collected your weights when you put them in and things like that. And they just released it was an update. I didn't release any study data from it, but an update on it a few months ago, and they've gotten some really good data. Now, again, right now, every little piece of data we get is better than the nothing that we already have. And so, in order to build something, you have to start with something. The first iteration of it is probably going to be a half measure, no matter how you do it, right? And so I'm encouraged that they're trying something. And my two hopes is, one is when they look at the population of people they look at that and say, okay, well, what portion of the population does that represent of the United States? And they don't try to oversell what they have. I don't want them to say, pregnant women in the United States have this. Like, no, actually it's, women with a household income of over, $40,000 who mostly live on the coasts. Right? And so I think that is important for them when they do that, because if they oversell it, people are going to knock it down like we just did to the last paper. But I do want them to do something. And now, if we keep going down this path, we're getting into a conversation about universal health care and the ability to do registries. And I don't know if we have enough time tonight to go through that.
Come on. The baby's asleep. I've got all the time in the world.
That's a different podcast. Although, maybe sometime in the future we can do an episode about the pros and cons of universal healthcare, and we can get Dr. Berge from Norway to come be the other side of that. All right, so we'll have to do that. We'll do that. But in any case,
so going around PregSource, what I'm looking for first and foremost, and this is where my mind has gone, given my patient population, is where is the Spanish
I couldn't
site?
find one.
Yeah. So that's I think one kind of big letdown right now. And then from beyond that, every other kind of different third, fourth, fifth most popular languages. That's I think huge. And otherwise, like you said, it's a good effort. You never want to get too cynical or too down on something that's being tried for the first time. But this is something that needs to be done at a provider level, and I don't even know what the first step would be on getting that.
Yeah, maybe this is just a proof of concept that the database, they can actually get the data in there and in a secure HIPAA way and whatnot. And then their next step will say, okay, now how do we recruit our partners to start putting information in? And if that works, then how do we get to the people who aren't our partners, and so on and so forth? So, we'll have to keep an eye on this and see where it goes over the next few years. But from our listeners, if you're out there in the U.S. and you have patients and you want to promote this, the website will be in the show notes, and I think it's something you can encourage your patients to do. All right, so I'm going to move on to the last one for tonight, because I do want to get back to Jerry and his postpartum narcotic adventure. But so the last one, actually, it's about hospitals. That's an attempt at a segue there. So this is a great article from Neil Shah. It was in Politico just this month. And it was talking about a project started at Robert Wood Johnson Foundation, or Dr. Shah is an OBGYN at Harvard. And what they're doing is they're studying the effect of our architecture and our infrastructure on labor, and really in medicine in general, but he's an OBGYN, so he's talking about labor and delivery. And I love his article because he starts with the history of hospitals and how they were designed. And as you all know, that's one of the things that gets my juices flowing, so that was exciting. I feel like I should ask him to come do this for a podcast for me. But what I really liked is, as our perception of what labor should be is being influenced very much by midwives, at least at Stony Brook, and Dr. Ballas can talk about where he is at Baylor. But we're getting this real pushback towards, you don't need to lay in a bed, right? And we've been going there for 10, 20 years, but it feels like it's picking up steam recently. So, you don't need to lay in a bed the entire pregnancy. I mean, you get up and walk around. We have the balls and there's tubs and whatnot, but we still have a labor room that is dominated by a bed, a birthing bed. And should we change that? And if we do change that, what is the effect on the woman? And she says, oh, maybe the bed's not so important and I should be doing other things. It doesn't encourage the kind of laboring that is maybe more beneficial. And then in the postpartum, do we need, the single rooms are good. We have those at Stony Brook, but then they're just, fluorescently lit corridors. Do we need more open spaces? Is it good to have spaces where women who just had a baby can sit together? Maybe, they can breastfeed together, they can learn from each other, as opposed to being isolated in their rooms. I just thought it was an interesting, the architecture and the building that we work in just kind of blends into the background because that's how it's always been, or if it's newly designed, well, that's how it is. But all those little things have an effect on how we take care of people, and it really got my mind going. What do you guys think?
Yeah, I think it definitely it perked my interest, and I guess made me think, I guess the way I view labor and delivery units and the way I view the labor course and how we manage patients, it does, I guess, is influenced a lot by the architecture of the labor and delivery unit that I'm in. I guess I would never have even thought about, for example, having a postpartum unit that's more like community-based. I thought, patients, of course, would love having single rooms and just in a room with a bed, or even thought about labor and delivery labor rooms to not really be dominated by the bed, because that's kind of really the biggest presence in the room is the labor bed where the patient is lying in. I think it made me think about my own perception of how I view labor and delivery, and then also made me think, how would patients react to this kind of article, and how would patients react to those kind of changes? Would everyone be agreeable to those changes, or everyone would be happy about those changes? Because I think the way patients view labor too is very much influenced by, the culture of the labor and delivery unit that they're in.
Yeah, I mean, it's as an example, when Stony Brook went to non-separation, where the babies stay with mom unless requested otherwise, there were women who said, can you please take my baby to the nursery? I want to sleep. Right? With my last two babies, you guys took the baby to the nursery. That was fantastic. Why are you making me keep the baby in my room? I want to get some sleep. And it was really funny. It wasn't a lot of women, but there were women who were generally upset by it. Anyway, what do you think, Jerry?
I mean, I'm a little torn from, in some ways, I think in terms of patient safety, a standardization between rooms seems to be the way to go, so that in the case of emergencies, we know where everything is, things are accessible from that standpoint. But again, that's thinking and designing for those rare events, and forgetting the fact that so much of labor and delivery is, for the most part, a not so much uneventful, but an uncomplicated, joyful event. From my experience between the hospital I work at and the hospital Regina delivered at, I mean, it's night and day in terms of the atmosphere. There's couches and all of the furniture is kind of wood-based or wood-looking to give more of a organic feel where we delivered, whereas my hospital, kind of like the article mentions, retrofitted has been built for 5 decades, has probably been rearranged several times internally, and they fit what they can wherever they can. And so it's basically an L-shaped unit leading to the operating rooms on one end. The rooms themselves are about as standard as you would see on any television show of what a hospital room would look like. So I can tell not much thought has been put into it in that regard, aside from your usual patient safety, patient standardization, and more from a hospital-based perspective of how a patient.
Well, that was one of the you hit on 2 points there. For me, one of them is hospital beds in general, hospital rooms, and with that, labor and delivery is built around us, right? It's built around the nurses and the staff and the doctors and the midwives. Mm-hmm. It's not built around the patient. Mm-hmm. And what you're saying about safety is 100% true. And there are some just realities of, JCO and, Department of Health's regulations that we have to follow. But I bet you if we took, 10 women who delivered, had no medical experience whatsoever, and asked them to design a labor room, you would get a much different layout. Mm-hmm. Right? And then
you may also get 10 different layouts.
Well, that's true. Well, you got to ask them to do it together, so they come up with one.
Right.
And the last...
Good luck. How is the nursery building with you? Come on. There's no...
Fair. The last thing, and this goes back to a conversation I think we all had the last time, or maybe, I forget who it was, about home births, and, I think maybe Sarah and I, about home births, is if we make our labor rooms more inviting, places where people want to go and be in labor and deliver, we'll have, I don't know how many less, but we'll have less women who feel the desire to do that at home. If we give them the experience that they're craving, that will get rid of some of that. And I say get rid of it. Maybe I shouldn't use that terminology because it sounds negative, but I really believe that delivering in a place where you have resources is just fundamentally safer. So I do want to get rid of home birth, but I want to do it in a way that gives the women the same experience they're trying to get at home.
The other part of that you always have to bring up is cost as well. I mean, I think a lot of when you start getting to these more unique designs or more comforting designs, I mean, it's unavoidable, but you're going to start talking cost. I mean, the one thing about current hospital beds and equipment is that they are mass-produced, easily replaceable. If one breaks, it's easy to get another. It starts to get harder when you start talking more custom-made furniture or custom-made equipment or looks to a room, and suddenly, our business is not a clean business. So that also has to play into some of these choices that we make.
Couldn't agree more. Everything is easy until you have to pay for it.
Right. I actually thought, because the rest of the article also talks about just hospitals in general, kind of getting rid of beds. The other way to look at it, though, is also this movement could be technically cost effective too, in a way, potentially, if women are not really staying in these rooms for long periods of time. If people wait, for instance, those who want a home birth, they kind of wait at home and come to the hospital for the delivery, and they deliver, and that's kind of what they say, like a birthing center franchises are aimed at birthing families being admitted and discharged in the same day and having more of like a home birth experience, and they go home. So if this is offered, and the hospital stay itself could potentially be lessened, and that could potentially save the hospital's money as well. So I think it kind of depends on which way you look at it. Are women going to be staying there for longer periods of time, and the equipment that we buy is more expensive, versus are people going to come and be admitted only when they really need to be admitted, and otherwise be waiting at home until they actually have the experience of having more natural labor course in the hospital.
Yeah, I mean, that's the whole thing there about transitioning some of the care we give to outside of the hospital, right? You could totally do that. You can even do that in New York, where we work. If you had a home nurse, a home health nurse, go there 12 hours later, or 24 hours later, and do the bilirubin on the baby, and you could do this, right? I don't know for the first baby. I don't know how many people want to take their baby home in 6 hours, but some safety stuff in there too. But you can definitely envision a world where you can do that. That requires a lot more coordination, a lot more resources. It's probably cheaper in the long run because hospitals are expensive.
Right.
All right, so I want to circle back and talk to Jerry. I want to get a follow-up on what's going on with the Tylenol number 3 experiment you guys are doing there at Baylor.
Well, like I said, we've the recent release of the worry between codeine-based medications in the postpartum period and breastfeeding sent up a red flag. And so, ironically enough, we are circling back to, believe it or not, narcotics. And so it's just this constant battle with balancing, appropriate pain management, which women need, with not, like we talked about with our one of our journal clubs, not allowing too much diversion of those medications for other uses.
Well, as they say, the best laid plans of mice and men.
Oh, absolutely.
So have you guys completely reverted to just narcotics now?
Pretty much for C-section short course narcotics, we're very diligent about how many we dispense. It's no longer the knee-jerk, here's 30, and on discharge. We take into account the pain scale much more for each woman, and anti-inflammatories. Also, our anesthesiologists have become much more aware of giving things like longer lasting medication into the spinals or epidurals like Duramorph. So we have talked to them about doing more tap blocks as well for C-sections in order to provide, a lot of the superficial pain that's the most lingering and most troublesome sometimes for our patients, and the ones that are touched the least by narcotics is more the superficial subcutaneous pain. And so we're trying to address that at the time of C-section. But also what we've taken on as an initiative for managing expectations. And that's where a lot of the pain literature now has gone, with not waiting until the postpartum period to address the issue. But we actually now have kind of a multi-pronged prenatal and antenatal workup to delivery, explaining to women what to expect in terms of pain management, options for management during labor, as well as postpartum. And I think we have no data yet on that or its effects. It hasn't been kind of universally applied yet. But I think that's probably going to be one of the new frontiers, is just really addressing pain up front and being realistic with patients about what to expect and what medications they should expect to go home with.
Expectation is so essential, and I think I've told this story before. There's what used to be a GYN oncologist at Brigham and Women in Boston, and all of his patients went home post-op day one from their X-laps. And so someone asked him one day, how do you get them all to go home post-op day one? He said, well, I tell them from the beginning that they're going home on post-op day one, and then they go home on post-op day one.
Right.
Right.
Mm-hmm.
I mean, you can argue the merits of going home day one, day two, but he was able to do that because that's what they expected. So I think you're absolutely right, Jerry. I mean, it's so stupid because we know this. Like, the prenatal intervention in education makes all the difference postpartum for almost anything.
Right. I mean, we saw that with our breastfeeding rates. When we talked about breastfeeding from the first trimester and normalized it throughout throughout the whole prenatal course, when it came time postpartum, when a woman is exhausted or the last thing she feels like doing is learning how to breastfeed, she feels like she's already been partially trained and taught and is expecting and is happy. And we have some of the highest breastfeeding rates in the Texas Medical Center now.
That's great. So, well, it's too bad about your codeine. But every experiment like that is something to learn from, and apply those to the next. And obviously, you're taking a different tact, and I think that's fantastic.
Yeah, something that I think as Stone April, we could also kind of take a look at our how we, I guess, counsel our patients and about pain, and also we could start thinking about, is there a way for us to decrease the number of narcotics that we prescribe to our patients too. So that's something that we could also try to work on as well.
Well, yeah, and if you want literature on it, actually a lot of literature comes out of the addiction literature. So how do you treat the patient with addiction issues that do not want to be on any kind of narcotics-based medications? And that's a enriched population where managing expectations really does help in the long run to avoid any pitfalls or relapses with your postpartum pain management.
Yeah, well, we'll definitely be in touch. Dr. Kim and one of her colleagues and maybe somebody else, we're doing a few quality studies and some research projects on exactly this topic. And I'm hope that you, Dr. Ballas, are also doing some data collection on this, because hopefully you can get a publication out of that, because I think it's interesting and it's timely.
Oh, it's timely. Oh, absolutely. This is on the foreground. Right
Knowing now. You, I know you are. So, all right. So I think that's it for tonight. Do you guys have anything that you want to add about any of the three things, or about the narcotics?
No,
I think we covered it.
Yeah.
I'm gonna keep poking through this PregSource. I might sign up as a pregnant lady just to kind of see what's
Fair enough. All right. You can report back next time.
Yeah.
I think next week or so, I'm going to try to get some people together for a journal club on a follow-up for antenatal steroids. I tried to get Dr. Breguet, but he's in Norway, which is a few hours ahead of us, and so it's a little difficult to arrange a time when we can get on the phone together and do this. So we'll keep trying, but he may not be able to join us. So look forward to that. I also, this month, should be starting a little mini-series here on aneuploidy, and I have an interview with someone who set up one of the first statewide aneuploidy screening programs in the United States. So that should come at the end of the month. You should look forward to that. Mm-hmm. And until next time, thank you all for listening. Good night.
Good night.
All right. Thank you.
Thank you.
Good night.